Let's talk about ulcerative colitis versus Crohn's disease. Now, one of the first things that you need to know, or one of the most important things you need to know between these two diseases, is the type of inflammation that occurs. Right? So, with ulcerative colitis, the inflammation that occurs is going to impact the mucosa as well as the submucosa. Okay? And this is very important as we're going to talk about in the video. So, with Crohn's disease is a type of transmural inflammation. This means that it is going to impact all the layers of the intestinal wall. So if you take a look at this picture, ulcerative colitis is going to impact the submucosa and the mucosa, whereas Crohn's disease is going to impact the submucosa and the mucosa in addition to the muscular layers and the serosa. So it is going to impact all the intestinal layers, not just the mucosa and the submucosa. Now, the colon involvement with ulcerative colitis, it is going to start from the rectum, and then it can travel all the way to the cecum. Okay, and this is in contrast to Crohn's disease. Crohn's disease can occur anywhere from the rectum all the way to the mouth. So sometimes patients can have ulcers, mouth ulcers. You won't see that with patients with ulcerative colitis, okay? Because it is only confined to the large intestine or the colon. And you can remember this by the CO in colitis, okay? CO for colon. This disease is confined to the colon, unlike Crohn's disease. Now, one of the other things that you need to know about ulcerative colitis and Crohn's disease is that with ulcerative colitis, the inflammation is going to be continuous, whereas in Crohn's disease, the inflammation is going to skip around. Okay, so the lesions are going to skip around. So if you take a look at this image, for example, here's a example of what you would expect with a patient who has Crohn's disease. These inflammations, they're skipping segments. Okay, they're not continuous. In the picture on the image on the left, if, for example, if in this image the patient had ulcerative colitis, the inflammation would start from the rectum and it'll be traveling. It can travel all the way to the cecum in a continuous fashion. So you won't see the inflammation skipping around. All right. And if we look back now, another important point that I need to reemphasize is that with ulcerative colitis, it is going to be confined to the colon. The rest of the dry tract is going to be unimpacted. Okay, rest of the dry tract is fine. One high yield fact you have to know about Crohn's disease that it is going to impact the terminal ileum the most. This is the segment that gets impacted the most. And what happens in the terminal ileum? Well, we get absorption of vitamin B12 as well as absorption of the bile acids, okay? So if you're not reabsorbing vitamin B12, we can expect our patient to have a vitamin B12 deficiency, right? And if we are secreting a lot of bile acids, what happens is this puts the patient at a risk for developing gallstones, right? And the reason for this is there's a cholesterol to bile acid ratio, right? And this ratio is important. If we are getting rid of bile acid because we can't reabsorb it in the terminal ileum, then this is going to increase the cholesterol to bile acid ratio, and cholesterol can actually precipitate out of the solution and cause cholesterol stones. And this is going to lead to the gallstones. Cholesterol stones are a common stone in patients who have cholelithiasis or stone in the gallbladder. Now, another important information we need to know about Crohn's disease is that the rectum is going to be spared in most cases. All right, so this is unlike ulcerative colitis where the inflammation is going to actually start in the rectum. Now, with symptoms, we need to, if we use our anatomy, we can determine where the abdominal pain is going to originate from. With ulcerative colitis, the rectum is involved. The inflammation starts in the rectum. Where is the rectum located? It's located in the left lower quadrant. So the patient is going to present with left lower quadrant pain. With Crohn's disease, terminal ileum is the site that is most impacted. So where's the terminal ileum? It is located in the right lower quadrant. So the patient will present with right lower quadrant pain in contrast. Now, with ulcerative colitis, we can have bloody diarrhea. With Crohn's disease, it is usually non-bloody diarrhea that occurs. On gross examination with ulcerative colitis, we will see pseudopolyps as well as the loss of haustra. These are things that we can see in imaging right here. These are pseudopolyps, right? So essentially what happens is we have this intestinal lining. There's inflammation that damages the intestinal lining, and there's going to be scar tissue. Once our body is trying to repair that damage, there's going to be scar tissue that is going to basically stack up and cause that polyps look on imaging. Here we see the loss of haustra is going to lead to the common lead pipe sign that's found in patients with ulcerative colitis. As you can see here, these are the haustra that are seen in this image. They're basically patches of the colon. This is the ascending colon, and this is the descending colon. The descending colon does not have those patches because, as we said, with patients who have ulcerative colitis, the inflammation is going to start from the rectum and is going to ascend its way up to the cecum. So the first site that is going to be impacted is going to be the rectum. So it makes sense that we see the loss of haustra in the descending colon first before the ascending colon. And now if we go back to contrast gross examination with Crohn's disease, with Crohn's disease what we get is these cobblestone mucosa, as well as creeping mesenteric fat and strictures. Okay, so if we take a look at this image, here is a mucosa, here's an under mucosa, here's an under mucosa. Between them, what we see is deep invaginations. Why do these deep invaginations occur? It's because of the transmural inflammation. The inflammation is going to occur in all the layers of the intestinal wall, so it is going to to lead to these deep invaginations. And the reason why we don't see this in ulcerative colitis is because only the mucosa and the submucosa are impacted, so we don't get the deep invaginations that we get with Crohn's disease. And now let's talk about the creeping mesenteric fat and the strictures that occur. So here's an example. Now the reason why we get this fat around the intestine is because where does fat reabsorption occur in the body? Well, it occurs in the intestine, and Crohn's disease is going to impact the intestine. And so if we're not reabsorbing fat, what is going to happen is we're going to have this accumulation of fat in our body in excess. And we're also having this inflammation going on in our intestines, so we need to repair that damaged tissue lining. And so it turns out that fibrous tissue is going to attract fat. And so we're going to ultimately have this fat around our intestine as a result. Why don't we get this in ulcerative colitis? Well, fat reabsorption is not impacted in ulcerative colitis. Why? Because ulcerative colitis is confined to the large intestine. That's not where most of the fat reabsorption occurs. It occurs in the intestine. Because ulcerative colitis leaves the intestine alone, we don't get this fat buildup around the intestinal wall. Now let's talk about some histology. With ulcerative colitis, what we get is these crypt abscesses with neutrophils. Okay, so let's write this down. Crypt abscesses with neutrophils. Here we see an example. If you look at the image on the left, okay, so this is normal. This is normal. This is normal. The one in the middle, let's highlight it with red. This one is not normal. Why? Because there are neutrophils that are in the middle. Why does this occur? Because there's damage that is going to lead to neutrophils coming inside. So there could be damage here, and all these neutrophils, they can then rush inside and be on the center of the crypt. Right? And this is a finding that happens in ulcerative colitis. If we take a look at Crohn's disease, well, what do we get as a hallmark finding? Well, with Crohn's disease, the hallmark finding is the non-cassetting granulomas. And this is basically a fancy way of saying there's going to be inflammation, but in this inflammation, we're not going to have any necrosis in the middle. So we don't see any necrosis in the middle, and this is considered a non-cassetting granuloma. All right, so let's talk about the complications. One of the fearful complications we get with ulcerative colitis is a toxic megacolon. Right, so this is when the colon is going to be basically distended as a result of not being able to get rid of stools and gas. So all that stools and gas, they're going to build up and they're going to stay in the colon, and this could actually rupture the colon, and this could be deadly for our patient. So this is something that we really fear, right? And all that inflammation can lead to cancer. So this is another important thing that we need to keep in mind, is that we need to give health checkups to patients with ulcerative colitis, because all that inflammation, it can lead to colon cancer for our patient. Now let's talk about the complications from Crohn's disease. Well, we talked about how the region that gets impacted the most in Crohn's disease is the terminal ileum, and so because the intestine is going to be impacted, there's going to be some malabsorption of vitamins as well as minerals. Right, so vitamin B12 is something that we really need to watch out for. Vitamin B12 is reabsorbed in the terminal ileum, and a deficiency can occur with a patient who has Crohn's disease. Patients with Crohn's disease are also at a higher risk for the formation of renal stones. Well, why does this happen? Well, we talked about how there's going to be a buildup of fat because we're not able to reabsorb that fat in the intestine. So what is going to happen is we're going to have these free fatty acids flowing around, and normally calcium is going to bind oxaloacetate. All right, so normally calcium binds oxaloacetate. Well, if we have this free fatty acids flowing around, because they're not reabsorbed, they're in the bloodstream, so these fatty acids, they're going to bind the calcium. And so what happens is we have an excess of oxaloacetate. And what is the most common stone, renal stone? Well, it's oxaloacetate stones. All right, so excess of oxaloacetate can put you at a risk for developing renal stones. And this is exactly what we see in patients with Crohn's disease, is that they have a higher risk of developing renal stones. Now, because we have transmural inflammation, we also have, it can also lead to the formation of fistulas. So basically, fistulas are opening in our bodies. So for example, here is the intestine, right? So here's the colon. I'm sorry. So this is the colon, and what is inside the colon is we have our basically our stools are going to travel from the bowel, and then it's going to leave through the rectum, and here's our bladder. All right, so because of the transmural inflammation, it can develop this fistula connecting our colon with our bladder. And what can ultimately occur is that we can have fecal matter in our urine, and this is called Cholovesical Fistula. This is a rare finding, but nevertheless, it can occur, right? So if we have, for example, skin next to where the inflammation is going on, it can create a fistula between that and the skin because of the transmural inflammation. Now, because of inflammation, that can also happen in our colon with Crohn's disease. Patients are also at a higher risk of developing colon cancer, so they also have to go through screenings to see if everything is going all right for them. Now let's talk about how smoking impacts these patients. So smoking with ulcerative colitis, it is supposedly protective. All right, the mechanism is not known, but for some reason smoking is protective against ulcerative colitis, whereas with Crohn's disease, it's going to increase your risk of developing Crohn's disease. So smoking is going to be protective against ulcerative colitis and is going to increase your risk for Crohn's disease. And thank you very much for watching.